Dear ladies and gentlemen, first of all, I have to say it's my pleasure to have you here. And of course, it's really a pleasure to talk to you. And this talk is focused on ultrasound, of course. And we have to opening a comprehensive toolbox. What does it mean? The focus on this talk is on different patterns of disease and showing this giant hemangioma with this typically enhancement pattern as an example. To understand how it works, I'd like to give you a short introduction and move on to this very special toolbox in different settings. First, I deal with a short quiz to you because this is a lunch symposium, and first I will explain how it works. This shows a family and an ultrasound image. Together, this is the ultrasound family. That's easy, but this is not a family, that's my family. And this is the quiz for you. Who is shown here? Starting with different paintings, and the first painter is 1.5 years old. You see some lines, some beautiful color, but it's very difficult to understand the pattern of the disease. This is from my daughter, 6 years old, and you see it's clearly a man because we can see a beard. This is for my oldest son. He's on puberty, so he don't have time for me. But after a while, this impressive image, and I think this looks much better than mine. And if you are a fan of Lord of the Rings, you will understand this must be Gimli, and I can show you the original cast. That's Gimli in origin. Okay, so we have to talk on patterns of disease, and first talk is on inflammation. This is a young guy with an acute onset on scrotal pain. In B-mode scanning, we see clearly a thickening of the epididymis. We can reconstruct the head in three-dimensional, and of course we see also the higher stiffness in shear wave elastography. But look at this. This is the value on SMI. We see typically the enhancement pattern here with the inflammatory rejection, not only on the epididymis, also here on the testicle, on the testis. Coming to the comprehensive toolbox, what does it mean? In my opinion, it's a translation to multi-parametric ultrasound imaging. And we have a lot of new tools, and of course, I have to explain this more in clinical details. Starting the next patterns of disease, vascular architecture. Dealing with lymph node staging, in my opinion, a future strategy could be three-dimensional reconstruction of the vascular tree, like in this example of a reactive enlarged lymph node, 7 millimeters in diameter, or in contrast to this lymphoma case, where we can see beautiful the vascular architecture based on SMI imaging. How it works in our daily practice, you see here once again propagation map, a higher stiffness of the cortex of the lymph node in correlation with a low vascularity here on the cortex region in contrast to the hilum. And of course you can pick up easily this area of interest based on your biopsy technology. Prostate cancer detection, why this is a big focus nowadays, because this is the most common malignancy in men with a clear increasing incidence, and you can see clearly here this is a problem of the Western civilization. This is our toolbox, so we can do a lot of things. We can do fusion, we can do strain measurements, SMI plus or without contrast, fusion biopsy, as well as shear wave elastography to picking up tiny lesions in a range of 78 kilopascal, like in that example. So the next patterns is hypoechoic on B mode as a question. And you know this guy, this is Mr. Watanabe. He is sitting on his transrectal ultrasound chair and scanning his own prostate. I'm not sure is this very comfortable, but he was the first author of these nice images, and he has the same problem. Hypoechoic, not always. And these are the major differential diagnoses if we deal with this topic, of course, benign prostate hyperplasia. And the problem is that we have only 17 up to 53% of the cancer cases are hypoechoic. But look at this, if we deal with contrast application in the fusion mode, you can see beautiful here this multifocal prostate cancer, much better than with the visualization in the MR scan, in my opinion. Coming to a clinical case, this is a patient, 72 years old. He has 2 negative biopsies in the history before and really a high PSA level. And we missed the cancer. This is a sampling of 10 cores and no cancer was detected. Why? Let us return to this special clinical case and look at this. This is an anterior cancer, well located here in the MR scanning, especially in the diffusion-weighted imaging with a high B value. That means a small cancer, but an aggressive one. What can we do? we can do sagittal registration and fusion. How it works. Load your DICOM data from the MR set, marker your lesion on your ultrasound platform in the axial overview, and then switch back into a sagittal scanning. Use anatomical landmarks like the bladder neck or the orthocontour of the prostate, set your marker, and then turn back into the axial scan plane. You see it here. Then look on your left on the MR scan, go back to the apex of the prostate, focusing only on the apex of the prostate to have a clear orientation, a perfect alignment to ultrasound. Switch to your set button, fix your image, and then move on to ultrasound. You see it here. We are on the apex. We're fixing the MR imaging. Yeah, here's the urethra, very well visible. This is the apex of the prostate. Now we set the marker button. And then we can switch back into ultrasound, go also to the apex, and we have a perfect alignment. And if we do things like that, you can see absolutely dramatic new informations in terms of SMI, because now we see neuroangiogenesis. This is not a hypervascularized lesion, but we see vessels coming from the orthocontour. And last but not least, of course, you have to do a puncture analysis, once again done by fusion biopsy. And look at the beautiness of imaging. We see here the mass and clearly also an ultrasound, and so you can pick up easily your anterior lesion. This is a new approach in our center. We deal with the topic on focal therapy of prostate cancer. We have to use irreversible electroporation because this is safe for the nerve and also for the vascular structures. And I'd like to give you a short overview how it works. Starting the session with a contrast overview, once again in the fusion mode. The tumor has a marker here, and we see there is very well perfused. Then we have 4 needles in the surrounding tissue in both scan planes, axial as well as linear, once again in the fusion mode. And 1 day after the procedure, you see this big perfusion defect in the surrounding area. So that means we are really successful. And of course, we have to double control this by MR, but it works perfect in my opinion. And this is a clear ongoing strategy for our future. New trends in abdominal imaging. As outlined before, we can do a lot of things. So the next patterns of disease is hypoechoic on contrast enhanced ultrasound. Focusing on pancreatic perfusion, of course, we can do a lot of things with this nice CT evaluation. That's clear. But look at this. This is an MR scan, and we can see easily here the perfusion based on ultrasound. The really fast inflow visualized on ultrasound after a bolus administration of Sonoview, and this is beautiful, and this is a normal pancreatic perfusion here in that case. Dealing with this nice publication from my friend Mirko Dinofrio, who made a decision. The statement is really clear. If you deal with this topic, we have the same sensitivity and specificity like in multi-detector CT, because it's easy to pick up an adenocarcinoma, especially in a low size, with a hypoechoic enhancement pattern on contrast-enhanced ultrasound. This is our explanation. This is an example of MR, where we see this typically double duct sign. This is the reconstruction of the same tumor, looking from the major duct into the tumor, 3-dimensional reconstructed, hypoechoic on B-mode scan, really high stiffness in the shear wave elastography, and typically hypoechoic on contrast-enhanced ultrasound. You can make the decision this must be an adenocarcinoma. Next patterns of disease, hypervascularity. Sometimes we have trouble to make a decision, is this an appendicitis, yes or not, especially if you have a diameter of 7 millimeters like in that example. And of course, then we have to use additional informations. And starting first with 3D evaluation, you see clearly there's free fluid first. Then switch back into SMI and reconstruct this 3-dimensional. We see beautiful, once again, the entering of the vascular architecture here in this inflammatory disease, and this is how it looks like in reality. So perfect matching here between SMI and the reality. Coming also to a new idea. This is really interesting. These are patients with Crohn's disease, and for us it's important to make a decision, is this a more fibrotic or an inflammatory gut problem? First of all, we scan the patients in MR, we see the area of interest, switch back into the fusion mode, make a decision which area is important. Then we used SMI in combination with contrast. We see hypervascularized gut, but we see an effective area where we have a really low perfusion. And if we correspond these findings with strain or shear wave elastography, we can measure a higher stiffness. That means, in that special patient situation, we have a combination of a fibrotic as well as an inflammatory gut. Coming to a hemangioma case, of course, we can do a lot of contrast applications, but look at SMI. It looks quite similar to the arterial phase after contrast application. So in some real clear clinical cases, I believe we can skip contrast application if this is a clear hemangioma with such an enhancement pattern. If the lesion is smaller, detecting by a staging CT on your left, we see beautiful, once again, hyperechoic and B mode. We switch back into SMI, color SMI, move on to monochromatic SMI. Look at this, beautiful to visualize the feeding architecture here of this special lesion. And of course, this is a diagnostic overkill. We can reconstruct everything three-dimensional now. So I love these images, of course, also for demonstration. The same case, having a contrast study available. And we do first flash to see the inflow, and then we double check with SMI in the late phase after 4 minutes after the bolus administration. And I can demonstrate we see the same things. So that's really important for the understanding. Next patterns of disease, decrease of vascularity and elasticity. That's very special. That's a very special study because we have here kidney graft recipients, and we are surprisingly have a kidney graft and a good graft function here and a kidney graft or a dysfunctional kidney. And it's really interesting that we can measure in the MR evaluation a higher stiffness in the case of good graft function. So firstly, we are wondering why, what is the reason? And of course, we double check with our shear wave elastography, and we can measure the same things, but in a higher resolution. So we can discriminate the cortex, the primaries, as well as the pelvic system. So that's really interesting, but we see the same fact. And the reason is clear if we look into the SMI Doppler technology, because we have a clear reduction of perfusion. And I believe this effect is much more important than the fibrosis. And that's the reason why the good graft function has a higher stiffness in contrast to this dysfunctional kidney. So perfusion, once again, is always the key. SMI and kidney, we have heard a lot. This is an angiomyolipoma of the left kidney. Beautiful, visualized on B-mode scan, looks like a soft kiss. Surprisingly, we will have this tonight. It's up to you. But if we use SMI, I must say a wish come true, because now we can see perfusion also in these beautiful angiomyolipoma with regular vascular architecture. So this helps you, in my opinion, to make a decision for your patients, maybe in three-dimensional reconstruction. So once again, everything is possible. This new toolbox is really important in your daily routine, but can we use this also for other specialties? Sometimes it's really difficult to discuss this problem with your clinical partners, and especially in my special situation, because my wife is a gynecologist. It's not always easy to discuss these new technologies. So it's starting this interesting approach where we have a so-called placenta accreta or increta, which is a potential cause of life-threatening hemorrhage or maternal hemorrhage, and it's really important to make a decision. Normally done by MR, like in that example, you see here the fetus, you see here the abnormal placenta structure, and we have to make a decision. Is this an increta, percreta, or accreta? Is the bladder involved, yes or not? Because this is really a risky case, or maybe a maternal hemorrhage could be very severe here in that example. What can we find out? We see first an increased thickness in ultrasound and in MR. There's no myometrium visible in both technologies. We see lacunar structures, and of course we know these are not lacunar structures, these are vascular architecture, and this is really beautiful visualized here on the SMI function. So we see clearly a hypervascularization. Next question is, this is the bladder, here's the bladder, and there's no infiltration. It stops here, and so we can see beautiful here in the SMI tool the vascularity, but we see also we have no bladder infiltration, so that means this is a special case of a placenta increta here. And of course, we can have a reconstruction so that you can demonstrate here's clearly a hypervascularity, so this is not longer a lacunar structure, this is clearly hypervascularity. This is the same lady, and they has also a midline neck mass. And of course, this was a horrible situation. So 2 points at the same day, and I'm using fly-through for this lady, especially to explain everything is okay, because this is a thyroglossal cyst, forms from a persistent thyroglossal duct, very special. But if you use fly-through, you feel like a surgeon. You can fly through the special duct here. And of course, I can tell the lady everything is okay. This is a benign lesion, so not a big problem. Coming to the end of the talk, coming to banana imaging. And you see, of course, we can do a lot of things. We can do an X-ray examination, CT scanning of bananas. You know this. This is how it looks like. But I think now we can use shear wave elastography to see a higher stiffness on the surface of the small banana. It's really important to understand this is the fresh one. You can do freehand 3D scanning of the banana, maybe after some cups of coffees. You can see beautiful here reconstruction, three-dimensional. And of course, you can do also three-dimensional scanning here of the big banana based on shear wave elastography. So everything is possible, and I have to say thank you so much for your kind attention. Thank you.